So welcome to this series called the Perioperative Coach. In this series we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk.
This piece is presented by Desiree Chappell and Monty Mythen with Mike Grocott and their guest, Michael Scott, Professor and Division Director of Critical Care Anaesthesiology at Virginia Commonwealth University. Have a listen.
One particular study that you said changed your practice and how you transfuse patients now.
Yeah, so basically I talked about preoperative anemia and setting up a clinic. We did that in the UK, and I'm pleased to say at VCU now, in the last year, we have set up a full preoperative optimisation clinic and trying to get this idea of clearing for surgery out of the window. It's all about optimising, because at the end of the day, cardiac events are not as high as we think, although there's some evidence you get this type 3 MIMS. Yeah. But it's more important to optimise things like haemoglobin, nutrition, avoid dehydration. And anemia is one of the biggest risk factors for surgery. We know that about a third of people going into major surgery are anemic. And so we can do something about it now before surgery. And so what I talked through was the
Sorry
fact
to
that...
interrupt, Mike, just so people focus on that point. So 1 in 3 people going in for major surgery are anemic. They have an inadequate level of haemoglobin.
Yeah, and that's large data. So that I'm quoting the USOS study of 47,000 patients across Europe and the study here in the USA. So we're not doing a good job, really, of screening people for anemia.
I think that someone wants to come in.
So, Mike, so I'm a big fan of anemia clinics, but we really sold ours on the basis that we could reduce transfusion, and therefore the business case is very straightforward. We've got lots of associative data saying that anemia is associated with a bad outcome, but do we truly yet know that what we're doing in our anemia clinics is improving outcome?
I think that's a good question, because we see there's a variable response. So basically the framework we use, anemia is very complicated, and you also have to exclude other causes, particularly cancer, if you're looking at elective orthopaedic surgery. But in most patients coming for urgent surgery, they've either got iron deficiency anemia from the problem that they're facing for surgery, or they've got anemia of chronic disease, or a mixture of both. And the good news is that we now have a fix, which is intravenous iron, which overcomes the problem of absorbing enough iron from the gut, either if you're losing blood, or if you've got anemia of chronic disease where you've got hepcidin activation, which blocks the iron going to your marrow and being absorbed. So you've got a functional anemia. So
can we just pause there for a second, because traditionally many of us would have grown up with the iron tablet challenge.
Correct, yeah.
Unpleasant to take for very many people. Yeah. Complicated dosing, because it's not as simple as take a lot of them, you absorb a lot more iron, and can take months and years to fix anemia. Is that
That's right, yeah.
Whereas the intravenous iron, there were challenges with anaphylaxis, etc. Now you can drop a bag of iron, and you can fix the problem.
So basically the newer iron formulations, iron sucrose, iron carboxymelose, you can give between 300 to 1 gram in a sitting. And most people, if you look at there's online calculators to work out iron deficiency.
At about a year, you can fix a year's worth of deficiency.
Absolutely. So if you've got a hemoglobin 11, your average iron deficit is 1.5 grams ish, just to give people an idea. So you can actually drop that into a patient in 20 minutes and wait for their marrow to respond. And you get a reticulocytosis around about 3 to 5 days. If people respond well, they respond by about 1 gram a week, is what we've seen in our work both back in the UK and here in the US. But you do get non-responders too, so it's not a total fix.
There are a lot of people, though, that will say that they have issues with giving IV iron.
I had the same challenges at VCU. Everyone thought, well, why am I, as an anesthesiologist, giving IV iron? But obviously I've boarded in internal medicine as well, so I feel more comfortable about it. But I use a slide to show the risks of blood transfusion in 1 single unit blood transfusion, and then the risk of an iron infusion, which is less than 10 in a million. There's a lot of nanoparticle reactions, so a lot of people do actually feel they're having a reaction. But if you give them steroids and antihistamines beforehand, it's a lot better tolerated.
I'm not tracking here. So, Desiree, did you say there are certain practitioners who are nervous about injecting iron?
Yes.
They're happy to inject heroin, human donor blood. Is that right? But they've got the iron.
Yeah, they have issues with it, and they're worried about the reactions.
Yeah. Okay. So the data I presented is from the US. Is you've got a risk of a serious blood transfusion still about 1 in 333.
Yeah, it was profound when you said that.
Even with cross-matched blood, you can get a delayed transfusion reaction at about 48 hours, and that's still about 1 in 500 to 600. It's quite surprising. So it's a low-grade reaction, but it's still there. Yeah. Then you've got all the other bad things that can happen if you've got cancer, increased surgical site infection, or risk of sepsis. We know from the Anaesthesia and Analgesia paper last year, the review, showing that it was about 9.6-fold risk for sepsis. And deep wound infection too. There's still a signal there.
Yeah. So when you put the slide up, that was what struck me, is that you had all these things, all these issues with blood, and
and yet people are still worried about an iron infusion.
And they're still worried about an iron infusion.
And I think that's a reflection of the way that we're very siloed in the US of whose problem is it. If you're giving the iron and there's a problem, you're the one that might get litigated against. Yeah. And it leads back to the whole movement of perioperative medicine and why perioperative medicine is important, because whose risk is it? It's the patient's risk. Yeah. And yet we're having people bow out of doing interventions because they're worried about the risk. And yesterday I talked in the pain meeting about epidural and risk, because if you are doing an epidural and saving someone having a pneumonia post-operatively, that has a very significant downstream effect on their life expectancy and outcome. Yeah. And the risk of an epidural might be worth taking. But the patient needs to know it's not just the risk of the procedure, it's the risk of the benefit. If you don't get the benefit, what are the alternatives? And it's the same with iron. Yep. So the data on orthopedics is really profound. I presented a paper from the American Medical Association which showed that transfusion rates were up to 25% in elective hip and knee surgery, despite the fact that there's only a 3% hemorrhage rate. So we're almost correcting long-standing anemia with acute blood transfusion just because it suits us at the time of surgery.
Get stuck on a number and I have to transfuse.
Yeah, and again, there was hard data at 5 years. This is a long-term outcome data, which really has changed my practice, because I didn't think blood was that bad. But it showed that the risk of anemia is there, but also the risk of a single unit blood transfusion at 5 years had a mortality impact of 10%. And that was where they case matched the patients and used regression analysis. So I think the data was quite powerful.
Yeah. So we on Top Mid Talk, Desiree in particular, you've recorded a number of interviews about anemia. Are you getting any mixed messages? I know we're probably interviewing enthusiasts, but
we are. No, I mean this is pretty common. We talked to Bobby Jean Schweitzer and Lori Heller at EBPOM a couple weeks ago, and we were talking specifically about setting up optimization clinics and utilizing anemia. But no, I mean it's all everyone's kind of jumping on board the people we're talking to.
So it does seem as though the improvements in the utility safety of intravenous iron is the big stepping point, because the EPO story turned out to be a little bit disappointing and harder to deliver. But the IV iron, obviously we always got to proceed with caution. Correct. But just on the transfusion avoidance and the relative ease of use, it looks as though it might be a significant tipping point.
That's right, and really what we should be doing is screening the patient as soon as they have that decision for surgery. Yep. And then I showed on Friday that we need all the haematinics and iron studies really to be safe. Yeah. But we should be giving that first iron infusion as soon as the patient knows they're going for surgery.
So are you cancelling... I'm sorry, Monty. Are you cancelling cases? And how do you have that conversation with your surgeons? Because it's a huge one.
Steve Cates, who's the chair at VCU for orthopedics, who is also on the HRQ grant, rolling out ERAS across the USA, he has got hard stops for everything. So we have a hard stop for anemia, having hip and knee surgery. No one goes for surgery who is anemic, unless they've got an underlying condition that we've tried to correct and we cannot optimise any further. So whereas urgent surgery for cancer is slightly different because you've got a time base there.
I mean, we don't have time for it today, but we'll come back to another time, is the... quite shocking data that's come out of universities who've looked at their students more closely, particularly young girls, female students, particularly exercising female students, particularly exercising vegetarian or vegan female students, and how common anemia is and its association with things like depression and fatigue. So,
I'm worried about that for my own girls, and encourage them to have a closer look at it.
I think it's been a revelation to me. I think we need to look at a population base and see how we can fix anemia in general. If you look at the world population, it's even more impactful because of the high incidence of other diseases. And so it is a fix we need to look at.
And have a conversation that women shouldn't have to live at have a lower threshold.
Well, that's right. So half of women with a hemoglobin of 12 are iron deficient. And the other thing we talked about is the fact that giving preoperative iron is a good thing because it helps recovery. And women are particularly at risk because, we know there's some work to show that blood loss is pretty consistent between surgery, and because women have a lower starting blood volume, it has a bigger effect on them, obviously, so they end up with a lower starting hemoglobin, but also they're iron deficient, so they can't make it up post-operatively so quickly.
Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher, or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.